planes assisting dissection, and this is called cavitation effect. Now also we have we have harmonic devices where we have ultra precision harmonic scalpel, harmonic ace, and harmonic. So here we can seal vessels. The first one can seal vessels up to 3 mm. The harmonic ace can seal vessels up to 5 mm, and harmonic ace plus can seal these vessels up to 7 mm. So other ultrasonic devices would include autosonics, sonicision, and sonosurge. So what are the advantages of these ultrasonic devices would be? There will be less tissue necrosis and charring, reduced lateral thermal spread, and less circulation. But here we have certain disadvantages also, that is slower as compared to electrosurgery. And the tip of this active blade needs to be away under vision, always under vision, and never touch visceral organs immediately after activation, as there is a danger of serious thermal damage due to high temperatures. So combined, now we also have combined bipolar and ultrasonic devices. The first device to integrate both ultrasonic generated frictional heat and also advanced bipolar energy, and this is in one instrument. It can rapidly cut, precisely dissect tissues, while advanced bipolar technology provides vessel sealing up to 7 mm diameter with minimal thermal spread. So here also in new technologies we have lasers. So laser devices emit a beam of photons with a high degree of spatial and temporal coherence. This is achieved by amplifying light of specific wavelength. There are a number of different types of lasers like carbon dioxide, argon laser, Nd:YAG laser, KTP532 with different properties. And advantages of laser are the accuracy of targeting the tissue and lack of lateral thermal spread. So in gynecology, they are mainly used for endometriosis ablation, as they are not absorbed by the unpigmented tissue, and thus abnormal tissues are preferably coagulated here. So, as we know, everything comes with a problem. Here, always a concern about the possibility of ignition or flammable material, accidental eye injuries, and laser beam may also be reflected by surgical instrument to the operating field. Now we have this also argon neutral plasma system. And coming to the tissue damage with different energy devices, all energy devices exert tissue effects with heat generation, and temperature above 42 degrees Celsius may cause tissue damages. So monopolar temperature at the tip of the instrument is usually 100.1 degrees Celsius, and harmonic we have 71.3, and bipolar and ligashore has usually 50 degrees Celsius. So I just like to thank you all and have a nice day. I have taken much of your time, so we'll start with the second one. Thank you so much.
Thank you so much, Dr. Nikita. You have explained very much nicely. If we are before any procedure, definitely that procedure will be very good. Thank you.
I request our chairperson, Dr. Rekha Singhal ma'am, to please present the memento to our speaker, Dr. Ritika Singh. To proceed with the session, I request our next speaker, Dr. Sonal Agrawal, to speak on the topic safe abdominal entry.
ये केवल से कर लें। हेलो, आवाज आ रही है? ठीक है।
A very good morning to everyone. It is a privilege for us to something like this happening in our city. We have never imagined that we can have something very specific to laparoscopy in our city. ये सब देखने हम बाहर जाते थे कि हम सीख के आएंगे. So I am very thankful to National Hospital as well as ROGS for organizing something like that. So my topic today is safe abdominal entry in gynae laparoscopy. As it is well said that the battle will begin is half won. तो अगर आपने लैप्रोस्कोपी में एंट्री सेफली कर ली तो आपकी सर्जरी का 70% पार्ट तो वहीं पे खत्म हो गया. If you have placed your port nicely, आपने कोई इंजरी नहीं की एंट्री में, दैट मीन्स आपका लैप्रोस्कोपी का 70% पार्ट वहीं खत्म हो जाता है. So my topic today is safe abdominal entry gynecological laparoscopy. So what we will do today? हम क्या देखेंगे आज? What is the introduction, importance of safe entry, anatomy of anterior abdominal wall, pre-operative assessment and patient selection, closed entry technique, open entry technique, direct trocar entry, optical entry systems, alternative entry sites, entry in special situations, complications and takeaway messages. So as we all know that 50% of the major laparoscopic complications occurs during entry, and out of these the majority are vascular ones, the visceral injuries, and 25% of the bowel injuries usually go unrecognized. We do not know that this has happened. So knowing is learning. अगर आपको पता है तो आप उसको मैनेज कर सकते हो. तो that's why this topic holds a lot of importance. And the safest technique, multiple techniques have been introduced since long. कोई कहता है वीरीज नीडल अच्छी है, कोई कहता है डायरेक्ट डाला तो अच्छा है, कोई कहता है ओपन अच्छा है. सो द बेस्ट टेक्निक इज वन इन विच द सर्जन इज कंफर्टेबल. जो टेक्निक सर्जन को सबसे अच्छे से आती है वही टेक्निक बेस्ट है. सो एज वी ऑल नो that we have 8 layers in the anterior abdominal wall: the skin, the subcutaneous fat, the anterior rectus sheath, the rectus abdominis muscle, the posterior rectus sheath. This structure is important that is absent below at the arcuate line, that is at the umbilicus. यही वो entry point है जो majority of the people choose करते हैं. Transverse facialis, preperitoneal fat and parietal peritoneum. In this the transverse, जब हम transverse fascia को prick करते हैं तो हमें first pop सुनाई देता है जो clip कहते हैं कि जब आप अंदर डालिए तो आपको एक रेजिस्टेंस जैसा फील होना चाहिए. और सेकंड जैसे ही हम पैराइटल पेरिटोनियम को अंदर जाते हैं तो हमें वो सेकंड क्लिप मिलता है. नाउ द मोस्ट कॉमनेस्ट, कंसिडरिंग दिस रेड पॉइंट एज द अम्बिलिकस, द मोस्ट कॉमन पॉइंट दैट इज यूज्ड इज द अम्बिलिकल एंट्री, followed by the supraumbilical entry, that is the Lewis point, and the Palmer's point, and these are all the secondary ports. Secondary ports are usually placed at a distance of at least 3 to 4 centimeter apart from each other. Secondary port placement is never difficult because it is always under vision. आप प्राइमरी पोर्ट डालने के बाद विजन में सेकेंडरी पोर्ट डालते हो तो दैट्स उनकी एंट्री में आपको कोई बहुत टेक्निक्स की जरूरत नहीं है. सो टुडे वी विल डिस्कस अबाउट प्राइमरी पोर्ट्स ओनली. So what is the pre-operative assessment that you should do? This is very important. हमेशा से हमारे सीनियर्स सिखाते हैं कि पेशेंट को टेबल पे नहीं देखना है आपको, कि जब पेशेंट को एनेस्थीसिया मिल गया तब आप सीधे उसको बस ऑपरेट करने आ गए. नो, a pre-operative assessment, a history taking is very important. We have to know that whether she has undergone any previous abdominal surgeries, what was the type, what was the approach, is she having any history of peritonitis, PID, any history of bowel disease. This is very important because अगर bowel inflamed है, swelled up है तो there are higher chances कि bowel injury हो सकती है. Then BMI, this is very important. The anterior abdominal wall की जो thickness है उससे हमारी entry site और technique बहुत influence होती है. और अगर कुछ previous laparoscopy पहले भी हो चुकी है तो उसमें क्या हमें कोई adhesions मिले थे, क्या हमें कोई उसमें structural abnormality मिली थी, that is very important. Then examination. Always examine for any kind of abdominal scars. Palpate for organomegaly. Go for an umbilicus thickness assessment. Ultrasonography is must to know for masses, free fluid, and also a CT or MRI if complex adhesion is suspected. When we do open surgery, we think कि हमें lean and thin patient मिलेगा तो हम जल्दी अच्छी surgery कर लेंगे. But the vice versa is for laparoscopy. In a very thin patient with a BMI less than 20, there are higher chances of injury to aorta because aorta is very close to umbilicus, just 3 centimeters below the umbilicus at the L4 L5 bifurcation. So these patients are to very risky category. Plus morbidly obese patients also fall in a very risky categories. And a patient with previous multiple surgeries, like we go for a 2 previous section, 3 previous section, or any endometriosis kind of patient. These are all patients which are a high risk patient for abdominal entry, and in these patients you should always have a supervised entry with an experienced surgeon जो laparoscopic experience हो, उन्हीं के साथ आपको ये surgery initially attempt करनी चाहिए. So how do we do a closed entry technique, a Vidi's needle technique? Always place the patient in a supine position, ensure that the bladder is empty, infraumbilical incision is given, intraumbilical in thin patients, elevate the abdominal wall. This is very, very important. Never try to make an entry without elevating the abdominal wall. If you, every surgeon, hold Vidi's needle like a dart, that is at a 45 degree. Advanced Trulay, you will have 2 clicks. Confirm the placement with safety checks. What are the safety checks? When you put gas, अगर आपकी Vidi's needle अंदर है तो आपका जो इनिशियल प्रेशर होगा वो 8 मिलीमीटर ऑफ मर्करी से कम होगा. एस्पिरेशन आप जब एस्पिरेट करोगे तो देयर विल बी नो ब्लड, नो बाबल, नथिंग. सलाइन ड्रॉप टेस्ट विल बी पॉजिटिव. There will be free movement and there will be no resistance. So after placement of Vidi's needle, confirmed placement of Vidi's needle is very necessary. Inflate CO2, initial opening pressure should be less than 80. Once adequate pneumoperitoneum, that is 15 millimeter of mercury is attained, we should insert the primary tumor. At this outset, I would like to welcome Dr. Ajay Hadar, our chief guest of today. Welcome, sir. So the open entry technique और Hazen's technique, is it for beginners? जिसमें आप इनिशियल बहुत ही मिनी इंसिजन अंडर विजन देते हो, पेरिटोनियम तक आप ओपन कर देते हो, उसके बाद आप वहाँ पे अपना पोर्ट डालते हो. लेकिन इसमें प्रॉब्लम ये है कि अगर आपके जो इंसिजन है उससे एक्सपीरियंस लैप्रोस्कोपिक सर्जन्स प्रैक्टिस करते हैं, जिसमें प्राइमरी ट्रोका डायरेक्टली एब्डोमिनल वॉल में इंसर्ट किया जाता है विदाउट एनी प्रायर Vidi's needle insufflation, and it requires adequate abdominal wall elevation. So the technique is same, that we should have adequate muscle relaxation. Infraumbilical incision is given. The important point is कि incision आपको abdominal wall को elevate करने के पहले देना है. After elevation नहीं, because वो जो आपका सेंटीमीटर की हम यहाँ बात कर रहे हैं कि 2 सेंटीमीटर ऊपर 2 सेंटीमीटर नीचे, you will miss that. तो आप पहले incision दीजिए, फिर abdominal wall को elevate कीजिए. Trocar is inserted with controlled force. This is very important. The guiding hand should be there. और आपको trocar हमेशा 45 डिग्री प्राइमरी trocar को रख के इंसर्ट करना है. A controlled force. Laparoscope is introduced to confirm intraperitoneal placement and CO2 insufflation is done. So what is the advantage of this? It's comparable to Vidi's needle. The only thing is if you are experienced, आप करते रहते हो तो आप डायरेक्ट trocar एंट्री करिए, नहीं go for Vidi's needle or a Hazen's technique. Now the newer systems are the optical entry system, जिसमें आपको हर एक anatomical layer दिखाई देती है और trocar abdominal wall में advance करता जाता है, like a visiport or endopath view or a step radially expanding trocar. So what are the entry points? Common used entry point is the umbilicus, intraumbilical incision, infraumbilical incision or a supraumbilical incision. The second point which is usually used is a leaf-van point, that is a supraumbilical incision. Very safe for gynecological surgery. अगर आप नए हो आप ये वाला यूज कीजिए, बिकॉज यहाँ पे आपके जो एब्डोमिनल ऑर्गन्स हैं उनकी इंजरी के चांसेस कम हो जाते हैं. अगर बड़े मासेस आप ऑपरेट करने जा रहे हो, दिस पॉइंट इज 2 to 3 सेंटीमीटर अबव द umbilicus. So useful large pelvic masses, greater distance from major vessels. प्रेगनेंसी में हम यही वाला पॉइंट यूज करते हैं and standard Vidi's needle can be used at this site also. The third point is a Palmer's point or a left hypochondrium point. This point is used when we know we have history की बहुत सारी abdominal surgeries हो चुकी हैं, previous midline scar है patient को, we are expecting कि हमें अंदर बहुत सारे adhesions मिलेंगे या anatomy थोड़ी distorted मिलेगी, then we use this Palmer's point. This is usually 3 centimeter below the left costal margin in the mid clavicular line. This is an adhesion free zone because it falls over the stomach. But while using this point, always decompress the stomach. NG tube is put. Always decompress the stomach because ये यहाँ पे अगर कोई previous stomach